Thank you for that really kind introduction. It's always a pleasure for me to come back home and attend meetings like this so that I can connect with old friends and make many new. But it's also an area where I have a huge depth of gratitude. I have a huge depth of gratitude for the basic medicine that I learned when I worked in Gynaecological College, Belgaum. And I think this has been the foundation of the care that I provide to my patients. So I'm really, really most grateful to my teachers, to my parents, and all the people who actually have provided me that knowledge and really given me the roots to develop. Without that, I wouldn't have been here. I also have a really soft spot for Mumbai. I did my first course for MRCOG Part 1 in National Hospital. I think it was in 1986. I was trying to remember. And in fact, it was at that time that I met Dr. Rishikesh Pai for the first time. So we go back a long time. In fact, you may just imagine how old we are. So it's a real pleasure to be here. And if at that time you had said to me that I would be president of the RCOG, I wouldn't have believed you. But even more, I would have thought that you are completely crazy. So it's a real pleasure for me to be here and give this oration. So when Rishikesh asked me to give this talk, I said, well, Rishikesh, what do you want me to talk about? What is it that people want to listen to? And he said to me, Ranee, talk about something you're really passionate about. Now, as many of you know, my passion is looking at the effect of childbirth on the pelvic floor. And I have a huge amount of research in this area, along with Abdul Sultan, who also happens to be my husband, for which I'm extremely grateful. But in addition to that, women with pelvic floor disorders have a huge impact on their quality of life. They suffer. And when I treat them, it gives me joy, it gives me satisfaction. And that's why this topic is just so important for me. So over the next 30 minutes or so, I'm going to take you on a personal journey, unraveling the pelvic floor after childbirth. And to do this, we are going to answer a few questions. We are going to start off with basics. What is the pelvic floor? And we are going to end with training, because training is the crux of prevention. And along the way, we are going to answer a few questions. Why is childbirth in humans so difficult? And because it's so difficult, what happens to the pelvic floor during birth? And what are the consequences for that? And if we want to prevent it, we've got to then look at risk factors that we can modify. And that's what we're going to do today. So join me on my journey. So what is the pelvic floor? Well, it's this muscle. It's complicated. It occupies the outlet of the pelvic floor. It's a complex structure. It's made up of muscle, ligaments, fascia. And the main muscle is the levator ani muscle. Now, this muscle is really complex. If you look at the picture here, you will see it is perforated by the urethra, vagina, the anal canal, and it has got fibers that go in different directions. In simple words, it keeps your organs in place. And because it keeps the pelvic organ in place, we do not get incontinence. It's really, really important. However, the complexity means that it hasn't been studied so well, as highlighted by this quote by R.L. Dickinson. And he said, there is no considerable muscle in the body, the form and function, because it has a function as well, which is more difficult to understand than that of the levator ani muscle. So I'm going to simplify this for you. So the next question is, what makes childbirth in humans so difficult? Well, it's the evolution. It's because we stand on 2 feet erect. Think about where we came from. We came from ape-like species, which walked on all fours. But about 4 million years ago, we became bipodadic, started walking on 2 legs. What this meant is that our pelvic structure had to change, and along with the change in pelvic structure, our muscle had to change so that we could have locomotion, so that they could support the pelvic organs. And as a result of this, the pelvis became smaller because the pelvic organs had to be maintained inside it. But 2 million years ago, there were further complications because the fetal brain started becoming bigger. And as the fetal brain started becoming bigger, it would not fit into the smaller pelvis. But if you look at the pongos, if you look at chimpanzees and gorillas, as you can see in this picture over here, you can see that the fetal head is much smaller than the pelvic outlet. But in the humans, it's like a corkscrew in a bottle of champagne. And really, that's what makes childbirth so difficult. The fetus has to twist, it has to turn through the birth canal, through the levator ani muscle, and then makes its way into the world. The most hazardous journey a person makes in their life. And one thing we all have in common here is we are born. And many of us, majority of us, have made this journey. But what we don't think about is what we have left behind. So that's what we need to do. What happens as that fetus is making that journey through that pelvic floor? Well, this is what happens. You can have nerve injury, known as pudendal neuropathy, but in addition to that, there can be direct injury to the muscle that I described, to the fascia and the supporting ligaments. So let's look at this. Let's consider what happens to the levator ani muscle. And in this picture over here, on the right-hand side, you can see that head coming out of that genital hiatus, that narrow genital hiatus. What happens then, as you can see on the picture on the left, is the stretching of the muscle, the elongation of those muscle fibers. And what does that lead to? Well, it stretches the pelvic floor, but within that, it also takes the nerve, the pudendal nerve with it. And here you can see that the pudendal nerve is actually quite short to start off with. It comes out of the lesser sciatic foramen, traverses in the Alcock's canal. And as that fetal head comes out, it stretches. That leads to pudendal neuropathy in women at risk. Now then, what happens to that muscle? Well, the best way to study this is through computerized images. And a lot of work in this area has been done by Professor Delancey, who is my absolute hero. Now, the blue sphere here is the fetal head. And then you can see the levator muscles. Now, early second stage, muscle is untouched. But as that fetus comes out of the hiatal genitus, what happens is the most medial fibers get stretched. They get the maximum tension. And what happens to a rubber band when you are trying to pull it till it cannot actually pull anymore? It breaks. That's exactly what happens to the levator ani muscle. As it is attached into the pubic bone, the most medial fibers are subjected to the maximum tension. And that means some of the fibers get detached. And that's known as levator avulsion or levator detachment or levator injury. Different people call it different things. But in addition to that, your levator muscle elongates 2.5 times from its original length. So what happens as a result of this? Two things. One is the genital hiatus and the levator hiatus get enlarged. On the picture here, you can see a normal genital hiatus, which is narrow. And then you can see an abnormal one, and the genital hiatus is much longer, which means the perineal body is shorter. So when you're doing your examinations on all your patients, have a look at the perineum, and you'll be able to say whether there's levator injury. This occurs in about 4 to 16% of women. But in addition to that, there is levator injury. A lot of work has been done in this area by Professor Delancey and also a urogynecologist known as Dietz. So there's MRI studies, there's ultrasound as well. And in the picture, you will see the pubic bone, the urethra, the vagina and the rectum. And where the black arrow is the levator attachment, and where the white arrow is the detachment. Now look at that picture of the vagina and the urethra and the prolapse, and you will see there is disfigurement and asymmetry. And you can actually then detect that there is an underlying levator injury. Now, the big problem with this injury is we cannot fix it. People have tried to fix it with really poor results. So what do we do about this? Well, that's why we need to focus on prevention. And that's what we have been doing over the past few years. Now, this is a systematic review from our unit, wherein we got one of our fellows to look at levator injury. We saw that about 1 in 3 women will have levator injury after vaginal delivery. But the important thing is that women who have this injury are more likely to have an anterior vaginal wall prolapse or middle compartment prolapse, so uterine prolapse. And it's also associated with a higher risk of recurrence after prolapse surgery. So it's really important for us to try and see what we can do to ensure that this muscle is intact. So this is one of the studies that we did in our unit. We got one of our research fellows to prospectively perform pelvic floor ultrasounds on women in the antenatal period at 36 weeks, postnatally at 3 months, and then at 1 year and 5 years. But in the picture down below, if you're not familiar, you will see a TUI of the pelvic floor done through a GE machine, and the white arrows shows you the detachment. So Kim, who did this study, found that the levator detachment after childbirth was about 21%, and it can be major or minor as well. But all of these women had had vaginal births. None of them had had a cesarean birth. So then we were interested to know, when does this occur? Does it occur in women who have emergency cesarean sections, who have gone into labor, or does it occur at the time of birth? So we got Candice, one of our fellows, to recruit women and got her to scan them in the first stage of labor, second stage of labor, and subsequently at 3 months. This is the image of one of our patients. You can see in the first stage of labor, levators look beautiful. They were intact. Second stage of labor, you can see the fetal head beautifully as well. Levators are intact. But in this particular patient, 3 months later, she had a detachment. And what that means is that this detachment is occurring as that fetus is coming out through the genital hiatus. That is the time of occurrence. And in the study that Candice did, almost 30% of women had levator avulsion. Now, what does this mean to women with prolapse? So often you do not see women with symptoms of pelvic floor dysfunction immediately afterwards. They usually occurs later on in life because of change in the collagen tissue, because of the effects of lack of hormones, etc. So there's change not only in the content of collagen tissue, but the type of collagen tissue. So what about women with prolapse? Now in picture A, you will see the levator hiatus is completely closed. So this is a pristine levator muscle which closes the hiatus. And that means all the pelvic organs are in position. Now in picture B, there is an avulsion. And therefore there's an imbalance in the pressures, and then the anterior wall starts coming down. And when there is a big genital hiatus, the vagina is exposed, and that pulls down on the uterus. And you can also see that the uterosacrals and the cardinal ligaments get stretched. And that's why when you do surgery for women on prolapse, you will see these ligaments are really very, very fine. So that's why women get pelvic organ prolapse. What about women with urinary incontinence? Why do women who give birth vaginally have urinary incontinence? Now you can see how beautifully the urethra sits on the vagina. There's fascia over there. But when there's fascial damage, when there's damage to the muscle and the nerve, you can see that there can be detachment. Try and imagine a hammock with one of the arms down. What would happen if you're sitting on it? You would fall off. So that's exactly what happens to the urethra. And as the pressure comes down, the urethra refuses to close, and the symptom the woman gets is stress incontinence. So we did a study where we looked at bladder neck mobility because we are interested to know what exactly happened. So we did pelvic floor ultrasound scan, and in the picture here you can see the bladder and the urethra. It's upside down because that's how the settings are. And we looked at the mobility, we looked at the rotation, and we found there was increase in bladder and bladder neck mobility, and also urethral mobility after childbirth in all women who had given childbirth, even cesarean section. But this was more in women who had levator injury, and it correlated to stress incontinence. So we hypothesized that after childbirth, if there is levator injury, those women are more likely to get incontinence of urine, and the pathophysiology over there is probably the injury that occurs to the fascia and the muscle. But we also need to bear in mind that there's likely to be nerve injury, which is difficult to measure. The other part of pelvic floor dysfunction, or the reason for this, is injury to the anal sphincter. Third or fourth degree tears, known as obstetric anal sphincter injury, which I will refer to as OAC because it's rather a mouthful. Now, OAC is the most common cause for anal incontinence in a woman, and this symptom is the worst symptom to be inflicted on any other woman. The cause for this is mechanical and also nerve injury. It occurs in about 3% of women who give birth vaginally, and more likely to occur in primaps than multips. Now, Abdul Sultan in 1999 came up with a classification for OAC, and he did this, as he tells me, to standardize care, to ensure everyone was speaking the same language, because at that time, people just said third or fourth degree tear, but your internal sphincter has a different function from the external sphincter, so it's really important for us to know the grade of tear. Now, we recently published a meta-analysis and looked at whether the grade actually makes a difference. And as you can see over here, Adana, who did this study, found that as the stage of OAC increases, the woman is more likely to have fecal incontinence. So we now have data where if a woman does have anal sphincter injury and you do the classification, which is accepted by most national bodies and also the international bodies, then you can counsel your patient. You can tell her what is the likelihood of a symptom if you know the grade of tear. What else happens? Well, there is a huge effect on sexual function as well, but the causation there is rather complex, and there are lots of different factors that come into play. That's a lecture on its own, and if you want to hear more about it, it's in the RCOG session tomorrow between 10 and 11. So I'm just going to now focus on urinary anal incontinence and prolapse and not talk about sexual dysfunction. So now let's look at the consequences of that pelvic floor trauma that you know about. One, how much incontinence can they get, and what happens in the long term? Because these symptoms are because of what happens at the time of childbirth. Now, this is a beautiful longitudinal study wherein they looked at women at 3 months, 6 years, 12 years, and 26 years. It's just published last year, later half of last year. And as you can see, urinary incontinence almost doubled at 26 years. Okay? Immediately after delivery at 3 months, it was about 33%, but it increased. It increased with time. And the same thing happened with anal incontinence. Now, anal incontinence is a combination of flatus and fecal incontinence. What is really interesting in this study is that exclusive cesarean sections, if a woman had never had vaginal birth, she had less risk of urinary and fecal incontinence. Not no risk, less risk. But they also were able to look at risk factors such as forceps, which was associated with a higher rate of fecal incontinence. And they also found that the high current BMI was a risk factor for all pelvic floor dysfunction. So you can see that we are looking at modifiable risk factors to reduce pelvic floor dysfunction. But what happens in the long term? Well, this is a beautiful study where they compared women who gave just one vaginal birth and had one cesarean section 20 years later. And they found after vaginal birth, the risk of OSC, the risk of urinary incontinence increased 2 times. There was no difference between emergency and elective cesarean section, and the prevalence of all kinds of incontinence, stress, urge, and mixed was higher. It was more severe and more bothersome after vaginal birth compared to cesarean. And when they quantified it, they said you need to do 8 cesarean sections to prevent 1 case of urinary incontinence. Not a good reason. What about anal incontinence? You can see that if you consider anal incontinence, almost 50% of women at 20 years will have anal incontinence. And it's more likely to occur in women who give birth vaginally. And if you quantify it, you need to do 26 cesarean sections to prevent 1 case of fecal incontinence. And again, no difference between emergency and elective cesarean section. So what about prolapse? This was one of the studies that we did. It was over a 5-year period. We scanned them antenatally, we scanned them at 1 year, and then at 5 years. And 5 years after childbirth, the stage of prolapse worsened after vaginal delivery, but not after cesarean section. But then we looked at the impact on symptoms and quality of life, and there was no impact at all. What that means is that the actual physical prolapse probably occurs earlier, but it's not so bad, so woman does not get symptoms. But as time goes by, as you can see over here, the prevalence of symptomatic pelvic organ prolapse symptoms is worse after vaginal birth compared to cesarean section. And you would need to do 12 cesarean sections to avoid 1 case of symptomatic pelvic organ prolapse. Again, no difference between the 2 types of cesarean sections. But again, if you look at risk factors, current BMI was a risk factor, modifiable, non-modifiable was the increased fetal birth weight. So it's clear that after vaginal birth, there is a higher incidence of all types of pelvic floor dysfunction, be it prolapse, be it stress incontinence, overactive bladder, or anal incontinence. And it's even higher with instrumental birth, as you can see over here. And as a woman gets older, it increases. So we've got to ask ourselves, is it just the birth, or is it other things as well? So I looked at all the risk factors, and I put them in a word graph, as you can see over here. And although there are different risk factors for the different dysfunctions, the main ones are age. You can't do anything about this. Obesity has a huge role to play in this. And with the increasing obesity, this is a really important thing that we need to bear in mind. Yesterday, we heard Nandita Palshetkar talking about obesity and how we can reduce it to improve fertility. Well, there's another area where we can also focus on reducing obesity. And this is something women do not know about. And you can see over here, there are other risk factors. Some of them overlap, some of them don't overlap. But these are important things that you need to inquire about if you see a patient with pelvic floor dysfunction. But it's really this lifespan analysis, this graph that has been suggested by Professor Delancey that helps us understand what happens to the pelvic floor over time. So you have phase 1 where you have predisposing factors. Say, for example, we take somebody who has a genetic predisposition to getting incontinence. And then in phase 2, there could be inciting factors such as vaginal birth. That would increase her risk. And phase 3 would be intervening factors such as obesity. Now, normally, if phase 1 and phase 2 didn't occur, even a woman with predisposing factors would have a reduction in symptoms. It would go below the symptom threshold. But if there is any disruption at any phase over here, that curve doesn't go down, it starts going up. And that's the explanation, and that's the importance of why we need to take a life course approach. Because I'll tell you what, most of these pelvic floor dysfunction occurs due to childbirth trauma or also effects of pregnancy, but they are not visible or they are ignored. And what happens after childbirth? End of postpartum care, either they go home like they do over here, or in other countries, most of the postnatal care stops at about 6 weeks. And these conditions, as I've shown you, can get worse with life as women get older and may present months or even years later. But nobody thinks that it was the childbirth that actually caused it, because we have stopped looking at it. And now you're going to ask me, well, how can I ever allow anybody to have a vaginal birth if her pelvic floor can be so badly damaged by childbirth? And you're absolutely right. But I think our job is to counsel our patients, to give her the choice. We also have to tell them about the dysfunction that can occur, the complications that can occur with cesarean births. These are immediate, these are delayed, and there's also risk to future pregnancy. But we do not tell that to our patients. I know we do not, because this paper has just been published. This is from the UK, which looked at women's experience of consent process for planned cesarean section. What did women say? Well, there was untimely provision of risk information. There were superficial discussions in the antenatal period, and just before she's going in to have her cesarean, she's consented and then told about all the risks. Well, it's too late for her to change her mind. You'll get upset. There was incompleteness or absent or sparse risk discussion prior to making the decision to go to cesarean section. And there was also emotional overload, such as fear of the risk. Imagine just going into theater and being told all of this, and fear that a cesarean would be denied. So what do we need to do? Well, as far as cesarean is concerned, our job is to counsel our patients. But then we also need to focus on prevention of pelvic floor injury. We do not need to get to that stage, and this is something we can all do at different stages in the antenatal period and at the time of birth. And we owe it to women to do that. So we did a study where we looked at the risk of levator avulsion injury at the time of childbirth, and the risk factors that we found were forceps, obstetric anal sphincter injury, and increased second stage. We have more recently followed up with a meta-analysis looking at all the studies, because there are more studies now. When we did our original study, there were very few studies, but now there are lots more. And then if you look at modifiable risk factors, it's forceps or vacuum, instrumental birth. And let me tell you that forceps is much worse than the vacuum, and also non-modifiable risk factors such as OAC and maternal age. With maternal age, it's important to remember that your muscles get stiffer, so they do not stretch that much. But there's not something we can modify. It's not within our gift to modify that. And then if you look at the risk of OAC, I refer to the green top guidelines. There is not much change in this area, but there are modifiable risk factors such as instrumental birth, again forceps. So you can see that there's an overlap between the two, occipito-posterior position and increased second stage. And again, there are a whole lot of non-modifiable risk factors such as nulliparity, maternal age, increased size of the fetus, and also shoulder dystocia. Now, what can you do? Well, something very simple. In the antenatal period, you can advise your patient to do perineal massage. This is very simple. Using any lubricant, the perineum is massaged as shown in the picture over here. This can be started at 34 weeks. And meta-analyses have shown that with this, there is a reduction in risk of OAC and higher intact perineums, but also lower episiotomy rates. But what can we do when you're actually assisting somebody to give birth? Well, warm compresses can be applied at the second stage, and that is associated with a 66% risk of reduction in OAC. Manual perineal protection can be done. That also reduces both third and fourth degree tears. And episiotomy, which is most common operation in obstetrics, well, not really now, it's cesarean section. But looking at where we do perform episiotomy, we've lost the art. Earlier on, you heard Frank talking about episiotomy. We need to think, does this woman need episiotomy? Is her perineum stretching? We need to go back to not being mechanical, but actually thinking why we are doing things. And then when that is performed, it should be performed correctly at crowning at 60 degrees so that you do not injure the sphincter. And where possible, we need to avoid forceps delivery. Can also agree that forceps is the only safe instrument in some circumstances, but if we can avoid it, it should be avoided because that will prevent both levator injury and sphincter injury. But we need to think outside the box because we are just doing the same things that we have been doing in the past. So the Odon, which many of you must have heard about, is something Tim Draycott is working on. It's like a plastic bag that's put around the fetal head and pulled out there. But you can see no part of the pelvic outlet is actually occupied. And I hope that this is going to be useful as far as prevention of pelvic floor injury is concerned. There's not much work done on pelvic floor injury over here, but it does look promising to me. I keep bothering Tim about this, and hopefully he'll start scanning these patients to look whether they do get levator avulsions. So what did we do in the RCOG? Well, the rates of OAC were going up, and our then president, David Richmond, was very worried about this. He called a few of us and said, can you come up with something we can do about reduction of OAC? Because we cannot just be watching this happening. So we got together with the midwives. As you're aware, in the UK, most normal births are performed by midwives. And together we came up with a care bundle of 4 interventions. 1, providing antenatal information to women on what they can do to prevent injury. What are the risk factors? We did this because most women who have this kind of injury do not actually know that they were going to have this. They just thought they're going to have a baby and go home. What they have now is incontinence. We also included manual perineal protection, performing an episiotomy correctly, and doing a rectal examination. And what we found is that this care bundle was associated with a 20% risk of OAC. This was mainly in spontaneous vaginal births, but interestingly, episiotomy and cesarean section rates were not or remained unchanged, which was good news. Now, we've done a lot of work in this area. We've also looked at women's experiences. We have explored clinicians' perspectives. And just this month, we have published a paper on the survey of women's experiences with the care bundle. I don't have time to go into that, but still the references are here if you are interested. But what about India? Well, we do not have very many studies from India, but there are small studies that are available. Different institutes, different people have done small studies in towns. For example, this study is from Vadnar. I chose it because it's near Mumbai. And they found when they asked women whether they had pelvic floor dysfunction, 40% of them had it. So women here also get pelvic floor dysfunction. The most common kind was urinary incontinence. 60% were aware of pelvic floor dysfunction. Only 35% knew about medical treatments. None were aware of physiotherapy, and therefore the author suggested community-based outreach programs. This is a study that is done by physiotherapists from the Somaya College of Physiotherapy. But the picture is the same in the UK. This is a survey we did in 2022. 3 in 5 women said they experienced symptoms of poor pelvic health after childbirth. There was a lack of awareness and education around this area, with 1 in 10 not knowing what the pelvic floor was, 1 in 4 had never done pelvic floor muscle exercises, and 1 in 3 didn't feel confident to do the exercises. So it's a situation, it's a global problem. And there were missed opportunities because about 70% had never spoken to anyone about their problems in the NHS. So what can you do? Well, in Croydon, we started one of the first perineal clinics in the UK, and we now know that they are present in most hospitals, but we also get a lot of international visitors who come to our unit to see what we do. In this clinic, we see all patients who have pelvic floor symptoms in the antenatal and postnatal period till about 6 weeks or so. And we review patients who could potentially have problems in the past, such as female genital mutilation and those who have obstetric anal sphincter injuries. And really, we want to get it right. We've got to work together. So we work with midwives, we work with the continence nurses and physiotherapists, and a lot of these women will have psychosexual problems. So we also work closely with a psychosexual counselor. But what we need to be doing is really focusing on prenatal education of women. Women need to be aware that they could get pelvic floor dysfunction after childbirth. They need to know about the potential risks of operative births. They need education on pelvic floor related changes. It doesn't have to be complex, it can be simplified. We need to screen people for pelvic floor dysfunction during pregnancy because this is a high-risk group. And they educate women on potentially beneficial interventions. And there is grade A evidence for pelvic floor muscle training, avoidance of smoking, avoidance of constipation, and also, importantly, maintaining normal BMI. Now, people do not like to read information on a piece of paper anymore. So let's get innovative. Let's use apps. In Southwest London, where I work, we have an app that we have created for antenatal and postnatal women. They can put their data in there. They can follow themselves up. We have online classes for women in the antenatal period and the postnatal period. And we have also developed several videos, and it's present in different languages as well. What about yoga? Yoga is very commonly done over here. There are some studies, and this is one of the latest studies that has just been published, and they found that yoga in pregnancy significantly improves pelvic floor dysfunction with no proven adverse effects, and that's important. So it can be done in childbirth. But then the important thing is to have continuous training in prevention of tears, continuous training in repair so that you get optimal results. This needs to be part of business as usual, what we do every single day. And in Croydon, we have it as part of our mandatory training for midwives and doctors. But we also have developed, as part of the International Urogyne Association, the PROTECT initiative, prevention, repair of tears, episiotomy, and coordinated training. And we have trained people to actually go out there and teach repairing the anal sphincter and also prevention. And Dr. Raj Maheshwari is the first certified PROTECT trainer, and she has trained many, many people over here. So if you all want to have training, she's the person to go to. We are training people so that they can go out there to their areas and then actually introduce training, because it's difficult for just one person to do all of this, or two people. So in conclusion, I hope I've covered all the questions that we started off with. You agree with me that the pelvic floor is a complex structure. It gets damaged at the time of childbirth. The mechanism of injury is nerve and physical injury. The consequences are pelvic floor dysfunction and sexual dysfunction. We can prevent it by looking at women who are at risk, and we need to have continuous training. But as you leave this room today, I really want you to consider that every time you look at an antenatal woman or a postnatal woman, you do not just look at that bump. You also think about the pelvic floor. You all need to be advocates for women so that they do not suffer from pelvic floor dysfunction, which has a huge impact on a woman's quality of life. Because we need to understand that part can never be well unless the whole is well. If you want to improve maternal health, you also have to improve pelvic health. This is some of my team who have given me great joy in my travel of unraveling the effects of childbirth on the pelvic floor. Thank you very much for listening to me.
Hello, thank you, Professor Ranee Thakkar, for a fantastic talk on pelvic floor dysfunction, injury. There's the lovely insights into the whole mechanism of it and how to prevent it. And I'm sure that all of the listeners who are there, nearly more than 2,000 online people are registered just now, who are actually online. 3,700 are registered, and I'm sure there's a lot of learning that they will have from your talk. Would you like to say something?
Yeah, and I think congratulations on your initiatives which you've taken. And I'm sure with RCOG backing those initiatives, it will really be helpful to the poor women. And as you mentioned in your talk, the quality of life genuinely gets affected, and working towards it and training of trainers is something which is really required today. And congratulations on that initiative. Thank you, Ranee. Thank you very much for this talk.